Good afternoon. So, because of limited time, so we are moving on to our next talk, which is COVID and COVID vaccination in GI and liver disease. Will be delivered by Professor Suranjith Senevirathne. He is a professor and consultant in clinical immunology and allergy. Currently works in Royal Free Hospital and University College London. I mean, he has delivered so many lectures to Sri Lankan audience, and it's going to be a very hot topic these days. So I'm sure that he will enlighten us with he will come up with the latest recommendation with the COVID and the COVID vaccination in GI and liver disease. So over to you, Professor Suranjith.
Thank you very much. Let me put my video. Okay. Thank you very much for the invitation, Sanjeev, and the Council of the Sri Lanka Gastro Association. Initially, I was asked whether I could do something on microbiome, but then this was very much more sort of topical. And that was the reason we sort of selected this topic to be because it's so topical within the world at the present time. So we all know that more than 5 million people have died in the world so far from COVID. More than 250 million people have got it. US, UK, Brazil, India, etc. have been the main countries that have been affected by this. Sri Lanka was doing okay, then had a small peak of cases, and these are the numbers in the different countries. You know the virus, RNA virus, and the reason I put this diagram is to show you the spikes on the surface, and the reason being that is what the part that the virus used to bind to the cell. It multiplies in the cell, spreads from cell to cell, spreads from person to person, and that's the part that can change, mutate, become mutated, and then the gene become mutated, and then what happens is the variants will occur, and that is a big issue in the world at the current time. So important figure just to have in your mind. Now, the summary of my talk would be a quick look at the basic aspect. I always like to go for the basic and then proceed on to the more advanced concepts, because otherwise it's difficult to put it into place. And then I will talk about the GI effects, the liver effects, and vaccination in these two different groups of patients, especially concentrating on IBD. You use a lot of medications, plus liver disease, chronic liver disease, and liver transplantation. So going on to the basic aspects of COVID and immune responses and vaccination, variants and vaccination, I always start with this figure showing you the immune system, the innate and adaptive immune system, the antibodies, the white cells, lymphocytes, which are extremely important in getting rid of infections, and including viral infection. And if it does not work properly and it can't get rid of those infections because of primary immune deficiency or secondary immune deficiency, because of the things we do to them, give them so many drugs, the different diseases they get, etc., then you find they have immune deficiency and they can't deal with viral infection. Then on the other side, you have a dysregulated immune system, autoimmunity, allergy, cancer, etc., where the immune system misbehaves, and sometimes the drugs we use for those can also affect the normal cells of the immune system. So these are the two parts of the immune system we have to take into account and balance it out when we have a specific patient. Cytokines are the sort of the language that the cells use to talk to each other, and like we use English similar, etc. And cytokines should be at a certain level. It can't be too high, it can't be too low. And the hypercytokinemia is something that we see in COVID and that we try to control at specific times. So the pathogenesis, immunopathogenesis of COVID, you can see here certain cells are increased, some are decreased, hypercytokinemia, etc., like IL-6, etc. And we use steroids, dexamethasone, and tocilizumab, the IL-6 inhibitor, IL-6 receptor inhibitor, in the correct perspective and the correct group of patients. And that is important, including gastro patient, to use these different agents at the correct time. Now, we also have two important advances in addition to the vaccination, that is the monoclonal antibodies, because vaccines take time. Vaccines prevent the disease, but if you get the disease, to prevent them become more severe, you have the monoclonal antibodies, the Regeneron antibodies and the AstraZeneca antibodies, and both these have been used now and are quite effective in the correct group of patients. In addition, we have the oral antiviral agents, which is a big advance and maybe a paradigm change with regards to COVID, again to be used early in people with risk factors for severe disease. So these are two important advances: monoclonal antibodies and the oral drugs. Again, the cost is a bit high at the moment, but they have done some licensing deal, and that should clear the way to reducing the cost. Again, there was an article in the newspaper today that we had just put together on these agents if you want to read it. So that leads us on to the variants. We know the variants of concern, variants of interest, 4 variants of concern, WHO classification, variants of interest, number of variants of interest. Why do we say that a thing is a variant of concern or interest? That is because we look at 5 things: its ability to spread, severe disease, diagnostic tests, therapeutic agents, and vaccine responses. If these are affected in an adverse way, it becomes a variant of concern. If they are not really affected at the moment, we just observe them variants of interest. So those are the 5 factors that we look at when dealing with the variants of the variants. And this is an important aspect for all of us to remember, because if we don't control the disease properly, we're going to get these different variants, and then the whole pandemic is going to go further and further. So again, lots of articles have been written by a whole lot of people. We have also contributed talking about the Delta variant, the Delta Plus variant, Mu variant, the Lambda variant, etc., with regards to SARS-CoV-2. Next, we come on to the vaccines. So I told you about the immune response, the variants, and the vaccines. 8 vaccines have been approved so far. 8 have failed. So not every vaccine that was developed did make it to success. So there are several vaccines that are good vaccines at the moment that are in use. This has been the sort of time scale. Months ago, there were 5 that had been rejected. Now it's about 8 that have been rejected, and 8 have been approved. So the vaccines that have been that we are using at the moment, quite good vaccines, are all against spike protein. There are mRNA vaccines, that's Pfizer and Moderna. They are the best vaccines. We have to remember that they are the best vaccine. The viral vector vaccine, the AstraZeneca, the Sputnik, and the J&J, and then you have the kill vaccines, that is the Sinopharm and the Sinovac. Why I tell you this is because your patients will be asking you which vaccine should be received, etc. And that is important to know this vaccine, the characteristics of the vaccine. And the best vaccines are the mRNA vaccine, especially when it comes to a 3rd dose, which I will talk to you about. Many vaccines have been given around the world, billions of doses, and you can see certain countries lead the way. Sri Lanka is great. It has come to a good level of vaccination. But then there are some countries that are lagging behind, Bangladesh, Nigeria, etc. But the problem with that is, if certain countries lag behind, this is a pandemic of the whole world. Certain countries lag behind, we're going to have a problem, because those people will travel to other countries. They will can develop variants and carry the variants away. So this has to be equitable and spread around the world about the vaccine rollout. You have efficacy and effectiveness. We have very good effective vaccines in the real world setting. What the vaccines are trying to do is reduce disease, severe disease, hospitalization, death, etc. It has done that very well, really good responses. It tries to reduce infection, asymptomatic infection, but it's not 100% there. So therefore, you can be infected even after vaccination and then spread the disease to non-vaccinated. So when non-vaccinated people are in a big danger, because they are not protected, and they can get the infection from the vaccinated person. One vaccine is not enough. You have to get 2 doses. You would not reach a threshold if you take one dose and just stop at that. You have to get 2 doses or more, because the 3rd dose has come in. So 1 is absolutely not enough. Pfizer, AstraZeneca, etc. It must be 2 doses. Vaccine responses are dropping. We didn't know what that was at the beginning of the year. 6 months, we are finding that the vaccine response are dropping. People are going for a 3rd dose or a booster, depending on the population that we're dealing. So that is another important thing to remember, because 3rd dose is coming to a lot of people. 3rd dose was given to immunocompromised patients. In the US, it was 1 month. UK, it was 2 months. And to other people, it was at boost at 6 months. So that has come in. We are using all our immunodeficient patients having given the 3rd dose. And this is so relevant to your IBD patient, because all are immunosuppressing them, and other patients that are immunosuppressed, people with cancers, colorectal cancer. That is extremely important. And this is, again, something we have written about COVID-19 vaccination in patients with cancer. So these are the groups that have to be protected and looked after, because they are the groups that will do badly, in addition to people who are older, people who have hypertension, diabetes, obese, etc. So this will lead us on to some basic aspects. This will lead us on to the specific areas of gastrointestinal and liver involvement in patients with COVID and their vaccination. I gave you the background knowledge so as to be able to get into what I'm going to say in the next few slides, because that will make it very easy as giving you take-home messages. So going on to the COVID-19 GI effects, a few months ago, we wrote a very extensive article on this aspect. All the sort of reports at that time have been put in there. You can read this. It's quite a long article. I didn't try to reproduce many aspects of it because there are more interesting aspects after that. So this is the article that was published. If you all want a copy, just ask me that. I'll give you a copy. And these were, we looked at SARS-CoV-1, SARS-CoV-2, MERS, etc., compared that and found out the GI involvement in the different conditions, and discussed the pathogenesis, treatment, management, etc., of these conditions. So if you look at this, we know that the SARS-CoV-2 virus, and COVID is the disease, SARS-CoV-2 virus can affect the lung, which is the main, it's a lung condition, but it can also affect the GI tract. And with the GI tract, you get the hyperinflammation, and then the immune system comes into place, the T cells and the B cells, and sometimes it recovers, sometimes it goes on, there's hyperinflammation, and the person deteriorates, and ICU and death. So the important thing to put in, I put in the drugs that you use for IBD. These are the whole range of drugs. Some are T cell drugs, azathioprine, mycophenolate, etc., cyclosporine. Then you have the other drugs like the vedolizumab, ustekinumab, etc., which act at different pathways. And this is important to know, because the question is, can we take these drugs? Should we take these drugs? Should we reduce the dose of the drug, etc., which is important to know. So these are the immunosuppressive agents that are used in IBD. Some of the agents, high-dose corticosteroids in some instances, TNF, vedolizumab, ustekinumab, and I've told you the role in viral infections, and does it increase the chance of viral infection? Does it increase the chance of severe COVID? And steroids, high-dose steroids, given for a long period of time, can affect. We give dexamethasone for treatment in an appropriate setting, but high-dose steroids you have to be careful, especially unlike some of the other biologics, but high-dose steroids are extremely important to remember. So the Europeans have come and given some do's and don'ts in people who are without symptoms. IBD patients, you just don't have to go and stop immunomodulators. You just continue the biologics, JAK inhibitors, you can reduce corticosteroid whenever possible and keep the infusions going. So you do not have to reduce the dose of immunomodulator and biologic in the people without symptoms. However, if they get symptoms, if they become symptomatic or asymptomatic SARS-CoV-2 positive, that's an important aspect. That is, they have now got infected and become symptomatic inserted. At that stage, you should consider postponing biologic administration, stopping certain agents such as azathioprine, mercaptopurine therapy, continue the prednisolone, don't continue prednisolone at a dose over 20, and you restart the treatment when they become PCR negative. The swab, nasopharyngeal swab PCR negative. So these are the guidelines that are given for patients with IBD, which we follow routinely. The Americans have very, very similar guidelines. Again, in the people who have no SARS-CoV-2, you don't have to do very much except for social distancing and the general measures and getting vaccination. No known SARS-CoV-2 infection with who are asymptomatic, all the thiopurines, etc. But if you're symptomatic, you go one step further and you restart the agents after they become a negative PCR. And the important thing is to balance the problems with IBD becoming worse and then deteriorating and sort of more complications occur and leading big dose of steroids or IV steroid, as opposed to the SARS-CoV-2 or COVID becoming worse and the patient going to hospital. So these are the recommendations that are given, the American and the European recommendation for IBD patient. Microbiome is important. I just put this because this was what I was asked to talk initially. So we know that there are big microbiome changes in acute, in post-acute COVID, etc. And people who have a bad microbiome have a high chance of getting severe COVID. This has been shown beautifully in certain studies. This is the bacterial component. Then you have the fungal component again that is changed in this group of patients. This is so important when it comes to long COVID, because that's what we're seeing so frequently now is people with COVID who have gone on to develop long COVID, and GI symptoms of one of the manifestations. You all are going to definitely see patients with GI manifestations. Fatigue, cardiac, respiratory, GI are the features that are found in this patient with long COVID, and that is something that you all will have to deal with. And knowing the manifestation microbiome aspects of that condition is important, because that is what the research is pointing out to one of the components of the long COVID. There are several other components, but long COVID is again an important aspect. So that is a quick run through with regards to the GI, focusing on the IBD aspect, and I will go into the liver aspects of sort of COVID and then go on to vaccination. So we know that the hepatocyte can be affected by the virus, but it is mainly the cholangiocyte, the bile duct cell. And there are different ways in which it causes liver damage. It can go into the liver cell and the hepatocyte and damage the cell, but not the commonest. It can be due to hypoxia due to the lung effects affecting the liver. It can be due to drug-induced liver injury. It can be due to thromboembolism, because in the people who had biopsy, there were microthrombi that were present, and a whole range, mitochondrial dysfunction, etc. So what happens is you can find that in patients with comorbidities and some milder liver disease, they can have increased COVID severity, and those with sort of chronic liver disease, you find that they can decompensate, and then mortality and severe COVID can occur, and then mortality can increase. That is well known. And this is a sort of a schematic to show that the worse that the liver disease, the child you see, if you find that the person has gone into ITU, it's about 90% mortality that the person would have. While in a person with chronic liver disease without cirrhosis, you find that once you go into invasive ventilation, it's about 21% mortality. So the important thing is treat these people early, watch out the condition, treat them aggressively, and don't look on and wait, because your chronic liver disease patient, if they get COVID, they have a higher chance of dying from the condition, especially if they decompensate. So that's an important thing to remember. Liver disease, chronic liver disease can affect the lung. How does it affect the lung? It has an effect on the antibody pathway, the T cell pathway, the immune response is dysfunctional. When they decompensate, you get ascites encephalopathy that can, in fact, cause a respiratory issue. And then you have thromboembolism, which is important, systemic inflammation. The liver has such an important role to play. So you have this crosstalk between the lung and the liver. That's so important in patients with chronic liver disease. So when it comes to transplantation, we use a whole range of drugs, liver transplantation, and then I'll talk about solid organ transplant, another important area. So you use a whole lot of agents like you would use in IBD, the immunosuppressive agent, whole lot of tacrolimus, cyclosporin, MMF, everolimus, etc. Some of those increase the chance, most of those increase the chance of getting viral infection. So getting SARS-CoV-2 is increased. And the second thing is that some of those drugs can also cause an increase in the severe to COVID, especially the mycophenolate group of drugs. So that is an important aspect to remember in your immunosuppressed patient and liver transplant patient. Mortality is increased in the liver transplant cohort. Several studies have shown that it's about 20-30% increase in mortality, and that is high for a patient with SARS-CoV. So look after your liver transplant patient, because COVID in liver transplant is a big problem, and that's why we vaccinate them very, very early. So GI effects, liver effects, I spoke to you, GI, IBD, liver, chronic liver disease, and liver transplant. Now about vaccination of GI and liver disease. The bottom line is just one statement if I'm giving you to take home is, please vaccinate these patients early. Do not look on and wait. Whether they are, I'll talk about liver transplant just a little bit, but GI patient gender, please vaccinate them early. They do need that. They need to be protected because their immune systems are not working properly, and you would be doing them a disservice by delaying vaccination. So if we look at the vaccination, COVID-19 vaccination in IBD should receive the COVID-19 vaccine. All three vaccines are safe. We don't have a live vaccine so far. either kill the mRNA or the viral vector vaccine. Best time to vaccine is when the earliest opportunity. Don't be looking on for the best vaccine, Pfizer, etc. Just give them the vaccine. I think that has happened in most countries now. Do not defer because they are on immune modifying drugs. Just give them the vaccine. Their response may not be as good as somebody who's healthy, but you can always give a third dose and boost that up. So that is an important thing to inform the person that they may need more vaccines. So when it comes to liver disease, we know, so that was about IBD and GI disorders in general. When it comes to liver disease, chronic liver disease, we know that generally vaccination not really great in peripheral chronic liver disease. Seasonal flu, hepatitis B, pneumococcal vaccines all have lower response in patients with chronic liver disease. The immune system is not working well. That is an area that you may not be putting too much focus on, but that is an important thing to remember. So again, vaccinate them early. Don't wait till their disease goes to very severe levels because the immune response will be worse. Now, when it comes to chronic liver disease patient, general vaccines I spoke to you, talk about the COVID vaccines, again recommended for all patients. You don't have to interrupt antiviral treatment, local regional treatment for hepatocellular carcinoma or treatment for PBC or autoimmune hepatitis. Just go ahead and give the vaccine. If there are a shortage of vaccine, go for the high MEL scores. And the important thing is if they have a sort of possibility of infection, look at that and exclude that they have COVID. If you have COVID, just wait 1 month and give the vaccine. And if it's a liver transplant patient on a waiting list, please consider vaccine before you think of before transfer, because you will make a good response. You don't want to immunosuppress them and then consider vaccine. And you consider the household members, very important, children and other household members and healthcare workers who are dealing with the social distancing and vaccination. The safety profile is fine, both Moderna and Pfizer vaccine, but also with AstraZeneca vaccine, both liver transplant in patients with chronic liver disease, liver transplant, etc. The safety profile is fine. They get some local safety sort of adverse effects, but a few systemic adverse effects also. When it comes to liver transplant patients, so I dealt with IBD, I dealt with chronic liver disease, liver transplant. Again, you please vaccinate this group of patients. Best time to administer is at least 3 months after the transplant when the immunosuppression is lower. But if it's an emergency, if it's more sort of a lot of comorbid factors, etc., just go at 6 weeks. Don't wait for 3 months, just go at 6 weeks. If there are a lot of comorbid feature, and you don't just reduce immunosuppression just for the reason of giving better response to vaccine, because there's a risk of acute cellular rejection. The only time we don't avoid vaccination if they're having acute cellular rejection and they are being treated at the moment. Wait till that is improved and then you can vaccinate. So these are what we follow when in our transplant center in the different hospitals here. Again, with regards to you don't, because they have been vaccinated, you don't delay donor transplantation, because it's difficult disease donor transplantation, because that is a vital organ, and if you don't delay it because the recipient had just got vaccinated. If a second dose is due in the immediate post-transplant period, just wait about 6 weeks before giving it. And in patients who are on the list, please vaccinate them at least 2 weeks before, because of the fact, both the recipient and the donor, because if it's a known time period, because the fact that it takes some time, takes about at least 7 to 10 days for the immune response to come. So these are some of the guidelines that we use with regards to the liver transplant patient. Finally, the last 2 slides, I will try to end up with telling you something about solid organ transplant, because that's just from another talk that I gave. Another important kidney transplants, lung transplant, heart transplants, etc., important in this perspective of vaccination. So antibody levels and seroconversion rates are lower in people with solid organ transplant compared to the population. We know that. That is why we go for third dose very much earlier without waiting till they get another infection or breakthrough infection. Safety is good, but the response is lower. And especially in people who are taking Belecept and MMF, that is, the response has been found to be especially lower in that group of patients. Additional risk factors for immunogenicity, lower immunogenicity is older age, shorter time for transplant, and worse graft function. So those are factors we take into consideration when dealing with when we give the third dose, etc. Potential strategies to increase immunogenicity: go and give a third dose or use higher doses. We are going for third doses. We give it after 2 months. And that has been shown in a lovely New England Journal article, and after that several articles showing that the third mRNA vaccine has a good immune response in those who were responding not so well previously. And the important thing to remember is give that without hesitating, give it after 2 months of the second dose, go for an mRNA vaccine because that is the better vaccine, the best vaccine around, better vaccines will come out. And people who are vaccinated, solid organ transplant, include liver transplant, please continue the precautionary measures because vaccination alone is not enough. Vaccination, social distancing, or antibodies and oral antiviral agents, those are the 4 things that are at the present moment with regards to treatment of this group of patients, liver disease patients, gastrointestinal patients. So in summary, what I've done now is spoken to you about the immune response in COVID-19 and how you decide treatment. They are the anti-cytokine treatment, the monoclonal antibodies, and the oral antiviral agents, again, to reduce the viral load. The SARS-CoV-2 variants of interest, and the variants of concern. COVID-19 vaccines, mRNA vaccines are best. Give it as a third dose. Give it, if available, first and second. But if you don't have that, give any vaccine first and second. But that's more important than having no immunity. GI effects, especially with IBD, I mentioned liver effects with chronic liver disease and liver transplant. The take-home message with vaccine: please vaccinate our patients early. Don't delay. Look after the immunocompromised patient, look after the cancer patient. That is a group of patients who would do bad if they get COVID and they get breakthrough COVID. Thanks a lot.
Thank you, Professor Suranjith. Thank you very much for the informative and the elaborative talks on the COVID and the COVID vaccination. So I'm sure that our audience will have a lot of questions, but we can allow 1 or 2 questions if you have got any. So may I ask 1 question, Professor Suranjith? So do you recommend any, the follow-up monitoring with any antibody response? I know that the best thing is to check the neutralizing antibody titer. So do you recommend, after the vaccination, do you recommend to check the antibody levels?
Yeah, so very good question, excellent question. I think not because it is good in studies. At the moment, we don't have a good immune correlate of protection. We don't have a good antibody correlate. We don't have a good cellular correlate. We use it in some patients with cancer, etc., to see if they made any response, but we cannot look at it in healthy people and not the GI patients who are not sort of immunocompromised or who have cancers or who have liver transplantation or the transplant, and then look at the antibody level and tell them don't give the vaccine. This has happened to a number of patients in Colombo and Sri Lanka, where the oncologist has said, no, your antibody levels are okay, don't go and get the third vaccine. That is absolutely wrong. That is not correct because we don't have a good correlate. People are using different assays to measure the antibody levels. In people, sort of healthy people, measuring antibody levels after vaccination, waste of time. They're just wasting a lot of money. That money should be used for diagnostic and other purposes. But if you're doing a study, it's okay. We do not have a good correlate. We use sometime on a sort of longitudinal basis in patients with, say, very immunocompromised or with sort of cancers. We may use it just to see whether there is a stepwise increase. But across the board, we just don't use antibody. We don't have a good cell assay. We are using the ELISpot and the Conferon assay to look at this, but it's not validated at the moment. So we don't have one good assay at the moment to use, and don't be wasting lots of money just measuring antibodies, etc., until we get a good assay. Hepatitis B, we have good assay. Measles, we have good assay, but in SARS-CoV-2, that will come. But at the moment, we don't have it, except in certain selected groups where you discuss with an immunologist or a good virologist about the assay to be used.
Any more questions? Yeah.
Is there a place for AstraZeneca vaccine as the third dose if you were vaccinated with the same?
Yeah, so now most countries are using the mRNA vaccine because they are the best vaccines around, right? So, but the thing is that you have to have the mRNA vaccine. If you have a shortage because you know the vaccine shortage that is there in people. Someplace in Africa, you don't even have 1% of people vaccinated. So if everybody is going for the Pfizer and the Moderna vaccine, Moderna has also been approved for third dose, then you'll find that there are going to be a shortage, in which case it's far better to go with a AstraZeneca vaccine as a third, because that is available, go ahead. But if you have access to the Pfizer or the Moderna, it is better to go with the better vaccine. That's what we always do. We go with first vaccine, the kill vaccine, Sinopharm, Sinovac. Immune response were not great, but have been used, that method have been used for a long period. So you always go, I know several people who have been waiting for Pfizer for months on end, not getting any vaccine. That is very bad. You go with the first and second dose, the Sinopharm, Sinovac, AstraZeneca, and if you can get a third dose of Pfizer or Moderna, go ahead with the Pfizer and Moderna. But if you can't get it, go with the next available one, because it's far better to boost the immune response to some level rather than not having that boost at all.
Okay,
so
thank you very much.
If you have the choice, go with the Pfizer.
Yeah, if that person has had 3 doses of AstraZeneca, is there a place for another Pfizer dose? Let's say now
Okay,
Pfizer
very
is available.
common question. Very common question. Now, important is in medicine, we always try to balance out, right? You don't want to, I mean, there are some in America that have got 5 and 6 doses, but I think that's a bit reckless. We have data on 3 doses, and what I have told people so far is, okay, wait, things change every month. Now, if you ask me the same question, sort of, can we mix vaccines in December 2020? I would have said, no, that's not good, may not be a good idea. But now mixing vaccine is better, because I'm giving a talk, I think 2 weeks to the Colombo faculty, where I'm showing the mixing vaccines but get a better response. But don't try to overdo it, go for 3 doses, wait till the data comes off with the 4 doses, because this is not like vaccination is, you don't want to get antigen overload, etc. So go for the 3rd dose. If there's sufficient data in certain people, plus after 6 months in healthy people, that 3rd dose is needed. But then don't just go and give 4th dose and 5th dose, etc. until we get the data.
All right, thank you very much.
Okay.
Professor Suranjith, the last question. So suppose that if somebody gets 2 doses of vaccination, and in the meantime, if they get a COVID, is there a place for 3rd, I mean the booster dose? And if it is, so when should they get the vaccine?
Very, very good question. I think that question we asked me about 3 times this last week. So so they have got 2 doses. They've got now people can get breakthrough infection. That is what we are seeing. Most of the patients who are getting to hospital, ICUs, etc. now are the unvaccinated, because they are the ones who get the bad infection. So after 2 doses, you can get a breakthrough infection, but most of them have mild, and then the immune response will improve. But they got the infection because the immune response could be waning off, and the recommendation at the moment is go ahead and give a third dose also at the correct time, but wait at least 1 month after the infection. So after the infection settles, wait 1 month and go and give at that time you go and give it, because we know that the vaccine immune response is definitely better than the natural immune response. That is what is happening in America. They are saying we are getting infected, we don't want the vaccine, but the CDC has clearly shown that if you do give a vaccine, the vaccine response are very much better than the natural. So the present guidance is 2 doses, you have got it. Now say most likely if you have got get the middle level, AstraZeneca, etc., Sinopharm or Sinovac vaccine, again, the immune response not so great. You get the infection, please go and get a 3rd dose, because that will boost the immune response to more appropriate levels.
So because
but
of the
1
time,
month after infection.
Yes. Thank you very much once again, Professor Suranjith, on behalf of SLSG, and we hope to see you in person at in our next meeting. Thank you very much, sir.
Thank you. Thank you very much. Thanks.